So we walked through a little bit of the stages of change and stages of treatment. So making sure that you, one, identify the stage of change the condition is in, and recognizing that the stage of change may be different for the mental health disorder and the substance use disorder, and then making sure that your treatment that you're providing is consistent with that stage of change. Now this is just to note, this is just kind of an FYI, that tip 35 contains the enhancing motivation for change in substance abuse treatment. So this is not tip 35, this is tip 42 that we're covering today. But if you want to get much more detailed information about motivation for change, you might want to check out tip 35. And while I'm at it, let me just comment, I think we did this in Module 1 as well, but if you want to obtain the tips, all you have to do is go to the SAMHSA website. They have a publications tab, and you can go there and identify which tips you want. Most of them you can download immediately and print off yourself. You can also order them for free or very low cost shipping as well. This one that I have here, I wanted to make sure I had it quickly, so I paid for expedited shipping, and I think it was $5. So it's not expensive at all. They're very reasonable. They really want to get the treatment improvement protocol information out to the field. So I would highly recommend you go to the SAMHSA website, that's SAMHSA, and the publications section and take a look if you haven't already. In fact, you can order more than one, so it allows you to order bundles if you want to order them for your staff. Okay, so tip 35, it also notes here that you want to take a look at the circumstances, motivation, and readiness scale. We talked a little bit about that during the screening module today. It's the relationship between the scales and retention and treatment for substance abuse populations. Also, client empowerment and responsibility. Every person, regardless of severity and disability, is entitled to experience promise and hope of dual recovery. So one of the other aspects of recovery principles is to ensure that you are empowering the people that you serve and instilling in them a promise that they're going to be able to have recovery from both disorders or establish recovery in both disorders. Continuous support. Encourage the client to build a support network that offers respect, acceptance, and appreciation. And this continuity of treatment, that services are constant and indefinite. Doesn't mean that they're going to be in individual therapy for the rest of their lives. It means that there is an availability of resources, that some of the treatment process will occur in a traditional setting. Some of it will continue to occur when they're out and about. That's also this concept of teaching them how to be their own therapist, that they can always use the skills, reflect back on them, know when they need to get back in to get some additional treatment, know how to access some of the self-help opportunities in the community. So that was 1 and 2. The third guideline for developing a successful therapeutic relationship includes managing countertransference. So we're going to talk about both countertransference and transference so you understand the difference if you don't already. So the consensus panel is listed in every treatment improvement protocol. It includes the various individuals who participated in the development of the TIP. The consensus panel recommends the following approach for managing countertransference with individuals who have co-occurring disorders. The clinician must be aware of any strong personal reactions and biases toward the client. So countertransference is how anything that you as a therapist bring to the table might impact the treatment modality. So if I walked into a therapy session and someone walked in and reminded me of this is a hypothetical example, but let's say it reminded me of a alcoholic uncle who I had a bad relationship with, does that connection for me affect my ability to treat that person? So always being acutely aware of any of these reactions that you may experience as someone who works with this population and how it might impact treatment. So what might I do if that came up for me? I might get supervision. I might talk with team meetings or peer consultation or supervision to get a sense of whether or not this is something that would be helpful for the client for me to continue working with them, or if I would need to refer them out. The clinician should have formal and periodic supervision to discuss countertransference issues. Transference describes the process whereby the client projects attitudes and feelings and reactions and images from the past onto the clinician. So, and these are attitudes that you need to check out with the client because they may not be apparent to you. If they walk in and they view me as their authoritarian father or their interfering mother or their know-it-all brother, they might bring some emotions and some history with those other individuals to the therapy session with me. Also with countertransference, and we talked about this a little bit in the context of secondary trauma, but understanding that clinicians are vulnerable to the same feelings of pessimism, despair, anger, and desire to abandon treatment as the client. I know I've been there, I'm sure others have as well, where you're working really hard, you're exhausted with working with a particular complex case, and you just start to feel like, I don't want to do this anymore. I'm feeling hopeless. This is not going anywhere. I'm not able to impact this case. That's another situation where you might want to get supervision. You want to find out whether or not a referral is appropriate or whether you want to work through it or can work through it. Having countertransference issues come up can make the clinician feel angry, used, overwhelmed, confused, anxious, and worn out. So that was managing countertransference. Let's move on to the next one, number 4, which is monitor psychiatric symptoms. The consensus panel recommends the following approaches for monitoring psychiatric symptoms with co-occurring disorders. Obtain a mental status exam to evaluate overall mental health and danger profile. Ask the questions about the client's symptoms and use of medication and look for signs of a mental disorder regularly. Keep track of any changes in symptoms. Ask the client directly and regularly about the extent of his or her depression and any associated suicidal thoughts. This is a really good step that I think is overlooked at times. If you work in a type of treatment organization where you have psychiatric services available, or even if you don't, but I'm sure you have some subset of your population that does receive psychiatric services, it's very infrequent that there is a lot of dialogue with the psychiatrist about some of the issues that go on with the customers. So I think it's really important to try to figure out how do you get more information that might help the psychiatrist in making decisions regarding medications. So it might be in several cases you're working with someone who has a chronic but stable condition. That could be chronic but stable in mental health diagnoses or in substance use diagnoses. And that's, very little need. Everyone is doing a good job, and medications seem to be working as well as medications can work, and you're doing your work to try to help the person achieve their goals. But then there will be some cases where, for whatever reason, the person just starts to have a change in their condition. So all of a sudden they aren't sleeping, they come in, they're agitated, they're having some problems that you haven't noticed before. Asking yourself, how do you get that kind of information to the person who's prescribing medications for that person? So that can be the psychiatrist, it could be the primary care doctor, it can be anyone it could be the nurse that's working with you. But making sure that that person knows that, something isn't quite right, something has happened that's different. Because often those med review sessions are so brief that by the time the person comes in, they're like, oh, nope, good things are good, get my meds, I'm on my way out. They don't take the time to explain or maybe even notice themselves that there has been a shift in their functioning. So when you're looking at the monitoring of psychiatric symptoms, thinking of all of the staff that interact with this person in the therapeutic setting, and how do you make sure that that information is being transferred. So we talked about the mental status, examine the symptoms, keep track of any changes in symptoms, and ask the client directly and regularly about the extent of his or her depression and any associated suicidal thoughts. There has been discussion in the past, I think it's pretty well known now, that it's okay to ask someone if they're having suicidal thoughts if you think they might. I think there are some that are concerned that if they say it, it might make the person have them if they aren't already having them, and that's just simply not true. Someone who is not having suicidal thoughts, and if someone says, are you having suicidal thoughts? You're going to be like, no, I'm not having suicidal thoughts. But being able to connect with someone and make it okay for them to share something that might actually be quite frightening for them, it's always a better idea to check it out than it is to not ask and hope that things just get better. So when you are assessing for a potential for harm, ask explicitly about suicide or the intention to do harm to someone else when the client assessment indicates that either is an issue. So as we just discussed, it's okay to ask the question, and you also want to get a better idea of intent, plan, means, likelihood. If the person comes in and says, I've had this fleeting thought, it kind of bothers me, I can't imagine myself doing it, I think it's probably never going to happen, I'm going to respond a lot differently to that. I'm still going to make sure the person's safe, but I'm going to respond differently to that than someone who says, you know what, I've been thinking about this plan for the last 3 days, I have everything I need to fulfill it, and I'm going to do it tonight. There's a very there's a distinction in those two, and you want to make sure that you have a better understanding of what's going on with that person. And also, if you, as we've talked about before, if you're not in a role where you're going to be able to put them in a safe setting, you need, as an organization and as staff, to know what's the protocol. Who do you call? What do you do if you have someone who comes in and starts talking about being actively suicidal? How do you get them connected to the level of care that will ensure their safety? Because that's very, very important. Also, monitor clients who express such thoughts closely. Ask about suicidal thoughts and plans as a routine part of each session. As I mentioned in a previous module, I don't ask it as a specific question. I think that would be pretty redundant if every person and make me look a little bit suspicious if everyone walked in, are you suicidal? Are you suicidal? It's not like that. But as a clinician, it's on the forefront of my mind, not just suicidal thoughts, but, is this person at risk of anything? Are they at risk of hurting someone, hurting themselves? Do they seem okay? Am I okay with them getting in their car and driving away right now? Any type of issue that may cause a red flag, you want to just be aware of it. Immediately follow up appointments missed by an active, acutely suicidal person. So if someone misses an appointment and you know that they haven't been doing very well, you want to follow up immediately with them. Management of the suicidal client requires securing an appropriate mental health professional for the client and having that person monitored closely. Often someone who's actively suicidal is going to be put into a psychiatric inpatient setting where they can be monitored. If someone is extremely actively suicidal, they may even have someone with them eyes on 24/7 to make sure that they don't hurt themselves. So even within a more intensive setting, there will be levels of of observation that might be needed to make sure that that person is safe.